Prepare to experience the strongest radio allowable by law. Secrets will be revealed. Myths dispelled. From the studio gym where excuses never apply, it's Superhuman Radio with your host, Carl Lenore.
Hey, welcome back to another episode of Superhuman Radio. We have an important topic today because everybody deals with pain at some point in their lives. And the older you get, the more you get. And we're going to be talking about pain, the perception of pain, and some emerging research that will help you understand and deal with pain better in just a moment. First, we have to thank our title sponsor, and that is Legendary Foods, makers of now the sweet rolls, which look just like those Cinnabons they sell at the airport and the mall cafeteria area, except they have 1 gram of sugar, 20 grams of high quality protein, and 5 net carbs. They come in cinnamon, chocolate, and wild berry. They're delicious. You'll think you're cheating, but you're not. When you eat these, you'll really think that they're the same junk that everybody eats, but they're not. Go to shrnetwork.biz/legendary. Use the code SHR10 to let them know that you learned about them here on Superhuman Radio. And while you're there, pick up some tasty pastries, which is a healthy alternative to a Pop-Tart. Same deal, actually less than 1 gram of sugar, 5 net carbs, and 20 grams of high-quality protein. And the kids love these. Now school's back. Put one of these in your kid's lunchbox, and all of his friends will think he's eating a horrible snack. Let's face it, Pop-Tarts are not good for you. But he's not, or she's not. They're healthy. So check them out. And without further delay, let me get my guest on. She's a returning guest, and she has taught our audience a lot about pain. How you doing, Amy Baxter?
I am fantastic. Thank you.
You wave like the queen.
Yeah, exactly.
That's good.
Got the move on.
So, most Americans deal with pain from time to time. Some live with pain. I've had to live with pain for many years because of bad surgeries on my left foot and the development of neuropathy, which we'll talk about because it's getting better for me. And the first thing they do is they look for a painkiller, right? I mean, most doctors go right to the painkillers. Is that a mistake?
What's interesting is that doctors actually don't learn about pain in med school. We get about 12 hours of pain education in the US. You get about 20 hours in Canada, and most of it is about pharmaceuticals. So yeah, it's a mistake, but I think that what's really interesting is both why it's a mistake and how we got to the place where we were on the cusp in the 70s and 80s of having a really good biopsychosocial model of pain management. And then some of the leftovers of the Sackler, Purdue Pharma, OxyContin debacle are that we still are left with a completely wrong understanding of pain.
Now you have a TED Talk that's coming out this month or next month? Next month, right?
Well, it depends when this is. Is this live when it comes out?
Yeah, this is live, so it's August 23rd right now. So
yeah, but yes, it is. So September 5th at 11 a.m. Eastern time at go.ted.com/Amy Baxter. That's when the talk that I gave in April will be released because it's Pain Awareness Month and it's Recovery Month. And the talk really is in this netherworld between why we're wrong about how we're doing opioids and why doctors still don't understand pain. And so we need to sidestep that and how everyday people can use new science to deal with pain.
Pain is a bad thing the way learning is a bad thing, but learning is not a bad thing. Learning is a good thing, and pain allows us to learn. Pain is an evolutionary gift to tell us what we're doing is not good for us. Would you agree with that statement?
I look at my highest truth from The Princess Bride, which says that life is pain, Highness, and anyone who tells you different is selling something.
Right. I like that.
Yeah.
But so doctors, and is it because none of us have the constitution any longer to deal with pain? You know, like we just can't, I just can't deal with it. Or is it really the doctor wanting to be merciful and extricate us from our pain? But the doctors treat pain like a bad thing, right?
Well, it really is this giant elephant, right? So lots of different researchers are going to look at this in completely different ways. But yeah, the kind of synopsis for most people following along with the opioid crisis is that in the 90s, you got a bunch of people who realized that we've had some racial and some gender disparities in treating pain. So that humanitarian group wants to increase awareness of pain and say, believe the patient. If you say you're in pain, you're in pain. And so the other part of it is that doctors get into medical school by being good at multiple choice tests. So we're used to one right answer, and we're used to a medical model, which is if I can measure it, if I can describe it in numbers, then I can treat it and cure it. So there's a bunch of fallacies in that one sentence that go along with pain. So first of all, you can't objectively measure it. You can't cure it. You don't want to your point. If you don't have pain, you can't learn how to stay away from pain and survive. And this concept that there's a switch to pain, or there's like one answer and there's a pill. And that came a lot from this teaching in the 90s. The other thing that happened was that a lot of independent physicians were bought up by HMOs. So now you've got a consumer approach to being a physician. You're a commodity. You're serving your customers. They're not your patients. And so there's pressure to provide what the customer wants. And most people, the number one reason they go to the doctor is for pain.
It's just fascinating. So when we look at pain, it's not really happening in the hand that I hit with the hammer. It's happening in my brain, right? I mean, there could be collateral damage to the tissue, but pain really happens in the brain, right?
That's so funny. That's exactly the way I start my talk. But yeah, if you bang your hand with a hammer and people think pain's in their thumb, but it's really happening in the brain. What is interesting is that it's not just like there's a pain place in the brain. Pain is this huge, elaborate reaction of the whole brain. So your impulse goes to the spine goes to the impulse goes to the thalamus then goes to a switchboard, and then the switchboard connects to all of the learning places that you need to make sense of this so you can decide whether you need to avoid it in the future. So from the switchboard, you're going to the amygdala for fear, you're going to the hippocampus for memory, you're going to the right frontal cortex for figuring out what options you have, you're going to identity, you're just going everywhere. So it's almost like pain is this massive explosion of lights everywhere in the brain, and most of them are what has happened before. They're not what you're experiencing. So pain is a guess. Pain is your brain's best guess of how safe you are.
You know, it's kind of like Tina Turner, love is a secondhand emotion. You know, like every pain that you're feeling is a secondhand incident. You felt something before. I want to throw something else in here that I just dawned on me. We now know that epigenetics is how we transfer intelligence in our species. The reason a baby deer knows to fear humans is because it was transferred through the germline, through the ovary, through epigenetics. So epigenetics isn't just about how these things are going to affect your health, but epigenetics actually transfer intelligence. And I would imagine that if the brain is that involved with dealing with pain, I'm sure it's feeding epigenetics so that future species know, don't jump off the building. It's not a good idea. I mean, it's like, no, really, it just dawned on me that I'm sure that's why the brain goes, pay attention. This is really important, Yeah.
Well, what is interesting is, and I'm sure that there's epigenetic components to it, definitely. The paper in 2020, which I found to be fascinating, by a guy named Thomas Spisak in Germany. So they're able to use functional MRI and watch where pain happens and see how it differs between people. And so Spisak found in this paper in Nature that there are all of these different connections that are different in different people. And so your resting pain connections very accurately predict how much the same stimulus is going to hurt you. So if you've got all of these laid down connections, now are they epigenetic? Are they things that happen to you? Still untangling, but there are predispositions, expectations, and connections that will cause you to feel pain more. There's another cool study, we may have talked about this last time, where they looked at the thalamus, that first place where your pain gets dealt with. They looked at the thalamus in people who had arthritis in the knee and needed a knee replacement. And you can physically see the volume of the thalamus has changed shape in response to the pain from a normal thalamus. And 6 months after a knee replacement, it's back to normal. So I think that's also really underlies this whole connectome concept, is that the brain is far from static, and it is constantly remodeling what it needs to keep you safe. And pain is one of the primary mechanisms of that remodeling.
So are we robbing the brain of that opportunity when we use drugs to circumvent pain?
That's an interesting thought. I hadn't actually thought about that. I certainly think we're robbing our immune systems of the ability to not become inflamed. So by giving babies Tylenol and ibuprofen when they have any kind of a fever, their bodies are supposed to be learning how inflammation is dangerous or not dangerous and learning how to stand down. So we're pretty sure now that a lot of the, especially acetaminophen use, but also ibuprofen that's being done for babies early on because we're afraid of fevers, is causing some of these autoimmune disorders later, because the body doesn't learn how to quiet its own immune system by itself.
That's fascinating.
Isn't it? Yeah. Yeah. It's, but apart from that, one of the other things to your point, so I actually didn't know this. I thought opioids turned off pain. And I don't know. I mean, I guess I assumed that that's what all these different opioids are doing. And they're not. They're activating a reward system. So you feel pain, but you don't care. Or you feel safe, so you don't worry about it.
And that's dopamine, you said, right?
Yeah. Yeah.
And
So
cocaine does the same thing. I know a guy who was coked out and got shot at a disco in New York when I was a young man. And he didn't feel the shot. Like he was wounded really badly.
Yeah.
But he was so coked out that, that he was in that dopamine overdrive. He wasn't sure he got shot until one of us said, "Holy F, you're bleeding, man. Look what you got shot." And he said, "I don't even feel it." And I don't think it was shock. I think it was the dopamine reuptake and inhibition of cocaine that made him feel like. And we always hear about people that are drugged out and they run into the gunfire and it doesn't kill them because they keep on running. So that's fascinating. That's how.
Well, and of course, I mean, cocaine is what we use in tetracaine, lidocaine. I mean, the cane is a sodium channel blocker. So it also stops the peripheral impulse from getting to the spine in the first place. But that's my whole paradigm now, is we shouldn't be thinking of pain as evil or good. We should think about pain as physiology, fear, and control, because those are really the ways to manipulate and to be empowered to address feeling pain. But the opioid thing, yeah. So it not only is it that opioids are going to the mu receptors, which is morphine, and they are powerfully activating the dopamine receptors. But one thing that's really cool is that's actually really useful. So for the first 24 hours after battlefield injury or a burn or a car wreck, the more morphine you get, the less post-traumatic stress and the less chronic pain. And that's been found in lots of studies, 2003 up until like 2015. There's a bunch of this research. But after about 2-3 days, the opioid receptors involute. They go back into the cell, so they're not available anymore. And that's part of why some of my message and why I'm here today is to say that the oral opioids that we're prescribing after surgery, those are worse than useless because your receptors aren't helping anymore. You're going too slowly for them to do anything. But I think that that's part of the complicated part of opioids is they actually serve a really good purpose early on. There is a new receptor that in mice has been found that will stop the development of chronic pain, but only if you block it in the first 48 hours. After that, it doesn't do anything.
And opioids don't block it. They don't do that, huh?
Don't know. I mean, that it's so new. So we know there's a receptor that if you block it, and it's different.
Yeah, new drug development.
Right, exactly. But it makes sense to me that with the timeline of when opioids are good at being protective for chronic pain or PTSD, I bet there's something in there with that FKD.
So what is the opioid doing if there's no receptor day 4, 5, 6, 7, 8, and people are becoming addicted to it? Is it just increasing dopamine? So now they're just like, oh, this dopamine feels good. I love this stuff.
So at day 3, 4, 5, 6. So day 3 is the critical day. After day 3 of oral opioids is when the addiction risk goes up. There's a couple different theories here. So first of all, when you're metabolizing a pill to the morphine form that's active. So codeine has to be metabolized to hydromorphone, which then has to be metabolized to morphine. So there's a couple steps. So it's somewhat slow. So the amount that's getting into your brain is maybe too slow to even trigger any of those dopamine feel-good things. And instead, all you're getting is constipation, sluggishness, and the physical addiction to the physical tolerance to the opioid stuff like the dry mouth and that kind of thing. What's risky is that about 5 to 15% of people, depending on race, are metabolizers of these medications at different speeds. So 5 to 15% are rapid metabolizers. And so they may get a rush that gives them the dopamine hit, but then it wears off so quickly that it doesn't do anything for pain.
So does this speak to the phenomenon that I've observed whenever you use something to deal with pain? So let's say you have pain, it's an 8, and you take something, Tylenol or something stronger. When it starts to wear off, the pain comes back as a 12, like the pain is worse. And so you need to take more. And then you have to take it more frequently. And you can't go as long. And it drives this like, oh my God, my pain is worse now. I have to take more of this. Is that just my imagination, or is that really a phenomenon that when you use a painkiller, the pain comes back worse than originally when you treated it?
So I call it the zone of fear. And by definition, when you have a pill, the way that we figure out what the right dose is, the pharmacokinetics of it, is to make sure that if you keep taking it at a certain period of time, it's not going to build up in your system. So that means that you're going to have the dose is going to go up, and then it's going to go down before you can take another one. And it has to go down low enough that you don't end up getting higher and higher and higher and higher levels.
Right.
So by definition, any pill for pain is going to wear off and go below the clinical pain relief level a good period of time before you can take another one. That's just how pills are designed, so that they don't build up. So the part about fear with pain is that a huge amplifier of pain is fear. So if you know you're in pain and you can't take another pill, then the fear is going to increase your perception of pain. Because again, there's no absolute, this is pain. It's a sum of everything in your brain that is predicting your safety.
So let's talk about that for a second, and let's go a little deeper. One of the things that I was given as a gift from powerlifting was the ability to ignore pain, like to know that I'm not a danger, this bar across my back or the way my hands feel as I'm pulling this weight off the ground. I have to tolerate it for me to achieve my goal. And so you really learn that, like, it's like telling a child, don't be afraid, that this isn't going to hurt you. And the child goes, oh, it's not. And they become tolerant of certain things. So you can actually start to tolerate pain. Is that, to me, I feel like that's valuable, because as we age, you're pretty much sure to start having aches and pains. And most people, they look for painkillers, or they just say, the hell with it, I'm just going to sit here all day. And I just muscle through it. But if the brain knows that this pain is not threatening, does it like learn from those events?
Yeah, it's so cool. Yeah, it does. It's so because pain is an opinion of your brain, you can also overrule it. And I think that we have been taught by, again, the Sacklers. So they said, okay, so opioids aren't addictive and you want to stay ahead of pain to keep your patient pain-free with this pill. So as much as anything, establishing pain-free as the goal is part of what has hurt our generation. Some of it is also impatience. We're not, Caesar said it's easier to find men to volunteer to go into battle to die than to endure pain with patience. And I gotta believe people in Caesar's day were more patient than with our immediate, how many milliseconds is my phone taking to load culture. But
Right.
yeah, so the thing about pain is that we are expecting it to be honest. We're expecting to not have any pain, and so therefore,
absolute. We're expecting it to be absolute, like this is a 6 decibel all the time. Yeah.
Yeah. Well, and so think about it. I mean, one of the examples I give is, and this actually is from a wonderful woman who's got a really great bit if you're going into surgery, called Judith Schenkman. And she said, look, the thing is, if you have somebody that knocks you over and you crash to the ground, it hurts a lot more if it's in a dark alley than if you're in the end zone holding a football. The meaning makes a difference, the context makes a difference, and your expectation makes a difference. If you know you might get hit and crunch down, then you ignore that pain because that's just part of the gig. So meaning of pain makes a huge difference. And I think there's a way to use this. And we talked a little bit about your leg, which I think is a great example. But since we last talked, fell off a bike at high speed and ripped 3 different parts of my rotator cuff. So labrum tear, bicep tendon insertion, and supraspinatus. And being an idiot, and it was around Christmas time, I decided to just tough it out for a while. And I started really babying the arm because I didn't want to hurt anything worse. Well, then I got impingement. Then it was much worse. And so when the ortho said, we're going to have to do surgery, I was like, is it 100%? He said, oh, I'm looking at your MRI now. That hurts so much. We're going to have to do surgery. And so I stubbornly was like, yeah, well, I'm a pain doctor. I don't think so. So what I did was really carefully find out what are the parameters of this pain that are endangering the fibers that are still there, and what doesn't matter. And so, I certainly had several months where pain was waking me from my shoulder every day, and it was exhausting trying to constantly be fighting it. But I just would, as soon as I was feeling pain from my shoulder, I would remind myself that, oh yeah, that's going to happen. It's not dangerous. And another cool technique that I learned is you become very attuned to sensations other places that are either positive or neutral. And so I would just shift my body's focus over to the other shoulder, which felt fine. And so now, 8 months out, I haven't had surgery, not going to have surgery. My strength and my mobility are almost entirely back. And I'm still having tweaks and pain sometimes, but I'm very comfortable now reminding my brain that it's not dangerous. And thank you for that message, but I can ignore you.
Yeah, that's amazing. Yeah, I mean, look at the surgery we used to do. Amputations. Here, drink this alcohol, drink this bourbon. I mean, look at the surgeries we used to do to people without real anesthesia.
Look at labor.
Oh, I know. Really, that's right. Women delivered babies way before we had hospitals. I mean, obviously we wouldn't be here if they didn't.
We still do.
Yeah. Let me put this.
Yeah.
God, I'm sorry. No, go.
Just if you imagine what happens to a woman's body when you give baby, and imagine someone torturing you and making that happen, versus the fact that after one baby, your good to consider having another one within a few, I don't know, months, years, but it's
death during childbirth is a real possibility. So I would imagine the fear factor also amplifies the pain, as you're pointing out. Like if you're afraid of your pain, it's going to be a lot worse than if you go, oh, this is part of the deal. I know what this is.
And I've done that. I mean, yeah, the second, third baby, I had my third naturally just because I'm into pain and I was curious about whether or not, what it would be like to not have an epidural. And knowing what to expect dramatically decreases your perception of pain because you feel like you're not as afraid and you know how to manage it and control it.
And also the baby feels that pain vicariously through the mother to some degree. I wonder if that actually kind of the way we say exiting the vagina benefits the baby's microbiome, if also the pain not being, epidural, whatever, actually primes the baby's ability to cope with pain moving forward, because it's like it had this pain, but it was great after that. Like, wow, this is great. I got to meet my mom and life is starting. I wonder if that affects the baby in some sort of evolutionary way that was good for the baby.
That is super interesting. I have not seen anything that along those lines, but I'm going to look that up. There certainly is a memory of pain that's not followed by a lovely cuddle with your mom in babies. So babies who have diabetic moms who have to get their toes stuck for a glucose every hour, they have much more pain if they then need to get a blood draw than babies who didn't have their toes stuck every hour. So knowing that you're getting pain and when certain touches happen, you remember that pain, even if it's not a memory that goes forward in life. But that the C-section thing is an interesting.
Yeah, I was a C-section baby. I mean, I was too big for my mother was only 5 foot tall. She couldn't deliver me.
Yeah.
So I was a C-section. And she smoked during the pregnancy and she took Librium during the pregnancy. So the fact that I can even make sentences is a big achievement for me.
Can you imagine how stratospheric your intellect would be if she was just eating organic?
I corrected everything by doing a lot of acid in high school. A lot, like a ridiculous amount of acid. That fixed everything. Let me put this question up. So Craig Hollander, who's an avid fan of the show, says he had a laminectomy of T7 and metal rods T5 through T10. I was left with a permanent compressed nerve. The pain was a 10 and hospitalized for 15 days. Oxycodone hardly helped me, but I needed it for 6 months to be able to learn to walk again. I took it every 4 hours around the clock. I weaned myself off when I could walk and remain in pain to this day. So you're still in pain? No pain med. So yeah, so you learn to live with pain. I know. When I was a young man, I had a therapist named Jerry Katz, and he taught me a lot. And he said, pain is good, Carl. He said, because if you sit in a chair and it hurts your back, you'll go out and find a new chair. And we don't want pain, but pain is an important part of learning, quite frankly. If your life sucks and you're in pain because your life sucks, you'll be motivated to fix it. So yeah, I mean, I live with pain. I'll talk about this now because we talked about it earlier.
And then I want to address him directly. But
oh no, please, you do that first. You do that first. You address him.
Yeah. So I think that there are a couple important things here, and actually, it's not a bad time to talk about the diagram. So hold off on putting the diagram up, which is just going to show about. Okay. But so you know that my current NIH funding is trying to reduce opioids for low back pain, right?
Right.
So what is really interesting is that it's using 3 different vibrating motors and heat or cold, and what we're finding that is fascinating is it doesn't seem to matter what, and I'm going to find these videos that I'm going to show because it's really cool. It doesn't seem to matter whether it's a pinched nerve or it's a Swiss cheese vertebrae or whatever it is. People are still getting the pain relief from it. And I think what's going on is fascia. And so because everybody that we've talked to who's like, I heard it in the military 20 years ago, I heard it, this time, all of those people are saying, I feel really loose. And so there are nerves that are in the fascia that are really only now being described that are causing pain. And so there's amazing, let's see if I can, all right. So I don't know if you're
Yeah, we can see. I think we can see that. Yeah.
okay. So there's no low back pain. So look at how that fascia is moving on the muscles. So you've got the white fascia and the muscles underneath, all
Yeah,
this moving.
it's moving independently of the muscle.
Exactly. So it looks almost like you've got a whole bunch of different flowing things. Now, exactly the same movements. So
Oh,
the
look at that.
person's bending in the same way, but this is somebody who does have low back pain. And so
The fascia is really almost not, it's not moving much at all.
it's not moving. And so that was from a 2011 paper by the woman who's now the head of the National Institutes of Health Complementary and Alternative Medicine. And so we're really just starting to describe these, the physiology part of pain, the part that is bringing the message in. And I'm sure it's, as is on your show a lot, that the whole concept of movement and why movement decreases pain. There's 5 different ways that movement helps pain. So, so I think that we're going to be learning a lot more about, especially now that we know that there are studies, Craig notwithstanding, there are studies that in general, low back pain and opioids are no better than placebo for long-term outcomes, and spinal cord stimulators are no better than placebo. I think a lot of what's happening is that it really matters the movement and the stretching to try to not have those fascial pain nerves stuck. The other thing, though, is, first of all, it's amazing that you were able, Craig, to wean yourself off of the opioids. But I think that, and now we can show the other side. So one of the points when I was getting ready for my talk and trying to figure out, where are the issues with pain? So people that are maintained on chronic opioids don't end up typically getting addicted, nor do they end up putting other pills into the system. So we never really should have tried to externally wean this. The CDC was wrong to take opioids away from people with chronic pain. Likewise, the opioids in hospitals, that dopamine rush when you've got a surgery, that's protective. That's important. Those guys rarely end up having issues. So the thing that is an issue with our opioid crisis in this country is these 84 million prescriptions that are written that are sent home with people after surgery, or that are short-term for wisdom tooth removal or anything else.
Mm-hmm. Mm-hmm.
And so what's fascinating is I went through and I did the numbers. So I spent about 8 hours looking at every paper I could find on how many people were still using opioids 90 days out who hadn't been before. And it's a fairly consistent 5%. I think that those are the people who are rapid metabolizers, and they are just getting this rush of well-being that most people aren't. We do know about 60% of the pills that are written for go unused. So here's the thing, Carl, that's crazy. The number of people that are new opioid use disorder patients every year is about 3 million. The number of pills that would be used is about 1.5 billion. And we know where they get them from, or they get them from their physician, or they get them from somebody's medicine cabinet, or they buy them from somebody's medicine cabinet, or they steal them from somebody's medicine cabinet. But these, the 22%, 44%, 10%, all that, that's where people who start misusing opioids get them. And if you look at the numbers, 84 million scripts is about 1.6 billion pills. And, 400 million of those are going where they're supposed to go. They're helping people with the pain, but the rest of them, it ends up being 1.17 billion are leftovers, or have people who've already.
So people just keep them in their medicine cabinet, and somebody comes over and says, "Oh, I hurt myself," and they give them a couple, or they use them inappropriately when they shouldn't be using them. So really, what we need to do is get like a buyback program where you return all of your opioids that are sitting in your medicine cabinet.
Or just don't give them at all. 6.4% of people with wisdom tooth, you can take this slide down probably, but 6.4% of kids who were given opioids for wisdom tooth removal were still using them 90 days later. And this is wisdom teeth. And there's really good data that ibuprofen works better for wisdom teeth. So maybe give 3 pills, but all of these enhanced recovery after surgery things for minor surgeries. So like not for spinal surgery, but for gallbladder, even for appendix, for wisdom teeth, for prostatectomy, for wrist pain, all these sort of things. If you have a whole bunch of options to help you feel in control and decrease fear, then ibuprofen and Tylenol will get almost everybody through. And what's interesting is a lot of those studies, they'll give people a prescription for 5 pills. And then guess how many people use when they get a prescription for 5 pills?
2.
They use 0 or 5.
Yeah. Okay.
It's not it's purely a mind thing. It's just do you feel like you need to have something to fall back on, or do you feel like, oh my God, I've got to use every single one of these, and then I've got to deal with it with heat or vibration.
I have a good friend who came out to me recently that he was addicted to opioids because of wisdom teeth he had extracted. The doctor gave him opioids, I guess Oxycontin, oxycodone, maybe oxycodone. And he said, Carl, they were amazing. Like I would take one and I'd feel like, wow, life is great. And he explained the whole phenomenon. I didn't realize the dopamine connection with these drugs, because I always thought like opioids make you sloppy. When I was a kid, we used to do Quaaludes, Secanols, Tuinols. I didn't like those drugs because they made you sloppy and lazy. I liked cocaine, meth. I liked the Black Beauties. I liked the uppers. And so it never dawned on me that they actually make you feel like you did coke, these opioids.
It's different people. What's your cytochrome P450 2D6? It's a genetic difference. Some people are rapid metabolizers, some people, and then there's also the euphoria. So this is something that was interesting about doing this talk. So I put in my talk that 1 in 8 people are going to feel so amazing with opioids that it's a risk. And they said, show me your data. And so I knew about so I showed them the rapid metabolizing data, and they said, yeah, but how does this make it risky for opioids? And I was like, well, duh, if they're feeling euphoric,
faster and harder.
So it turns out there's very little that has been done looking at euphoria and addiction. There's been a lot done looking at rapid metabolism and whether you need to give them more opioids because they're going through it so fast that they're not going to get the pain relief, or slow metabolizers. But there's not a lot. The one paper I could find was in 2008. Someone looked at people that were on chronic opioids for various different genetic diseases and who had developed opioid use disorder and who had not. And the ones who developed opioid use disorder were 16 times more likely to remember feeling euphoria with that first dose.
Mm-hmm. And then you chase it.
One of the I've been talking to a lot of recovery groups, and one of them is Voices for Non-Opioid Choices. And the guy who runs it, Chris Fox, he's like, every parent I've talked to said, my child finally felt comfortable in their own skin. My child finally felt loved and happy and comfortable and powerful. How could I take that away from them? Woman I worked with became opioid use disorder patient after, she's in the nurse, she's my trauma nurse. And so one night I diagnosed her with a gallbladder. I was like, yeah, it's probably gallbladder. It was. She had the surgery, and that was the first time she'd ever had opioids, and she became addicted, and she was stealing fentanyl from kids. So I asked her what on earth, after she'd gone through recovery, and I said, how'd this happen? And she described exactly that same thing. She was like, I finally felt comfortable in my own skin. I felt fantastic. Most people don't. 85% of people, we just
and that's the difference. That's the who's more susceptible to addiction than not. Let me just hit a couple sponsors real quick. If your sleep sucks, Bioptimizers has an amazing product called Sleep Breakthrough. We've done shows about it. People love it. If you go to shrnetwork.biz/Bioptimizers and use the code SHR10, you'll save 10% off. You drink it right before bed. It puts you to sleep. It keeps you to sleep, and you don't wake up in the morning groggy. White Oak Pastures is the best place in America to get your grass-fed and pastured meats. Will Harris he's been so instrumental in opening the eyes of people to regenerative farming that he got him on Joe Rogan. In fact, he's doing an interview very shortly with RFK, Robert F. Kennedy Jr. They have been a sponsor on our show for years. I love their meat. I learned that a lot of people eat grass-fed beef. They say the steaks are always tough. You got to wet age them, leave them in the plastic bag, the plastic sealed bag that it comes in. Leave it in the refrigerator for 20 days. You're gonna be like, Carl, but no, leave it there for 20 days. That's called wet aging. The meat will be so tender, it won't be bad for you. It tastes amazing. Go to shrnetwork.biz/white oak. Use the code superhuman for 15% off your first order. I don't do the commercials anymore. Now I only have a few as sponsors, and now I just talk them myself. All right, so let's talk about pain management. The first time you came on the show, you were working on a product for people who had pain. What's going on with that product?
Well, we started with, first a pediatrician, and I discovered a frequency of vibration that would block needle pain. And it turns out that what you're doing when you're, bang your hand with a hammer, the shaking that you're doing is triggering the pacinian corpuscle. So the frequency that triggers that particular nerve is about 180 to 200 hertz. So we use 200 hertz. One of my colleagues used that device to not take opioids after a total knee replacement. That was when I decided to quit practicing and try to see if I could figure out what was going on with this pain thing. So in the course of that, we had a local orthopedist who used the device, and I'm not, unless I can, but I don't want to say the names because you got people who are sponsoring you, and so I don't want to plug the product. But
the orthopedic surgeon, you mean?
Yeah. So the orthopedic surgeon used the devices. He was studying opioids after ACL reconstruction, and he'd been giving people 50 and found that his athletes were taking 25. So he was like, okay, I'm going to see what happens if I give them 30, and they would then take 15. And so, no change in pain. So anyway, so he was doing this. So he was interested in the opioid stuff. And so he said, yeah, let me do a study on the device. So he had these vibration and cold compression devices. And he got so interested in his opioid thing. He said, you know what, I'm going to have my other guys do the study. Reduced opioid use 35% without any coaching, because his group was having coaching on opioids and trying to not take so many. Didn't even need it, reduced to 25%. Here's where it gets interesting. He wouldn't publish it unless I gave him 2% equity or $200,000. Come to find out.
What a sport.
Come to find out that was a bargain. So the deal is that Medicaid and Medicare are designed, like statutorily, they pay for illness and bodily deformity, which means that they pay a ton for like back braces and things. So a back brace after surgery gets reimbursed for $1,600. What the orthopedists do is they rent space to a durable medical equipment company that will hold that back brace and fit it to the person. So manufacturer makes it for $40, sells it to the DME company for $400. The DME person fits it for $300 in the office. The orthopedic office keeps $900 of that $1,600 that they bill insurance for or bill Medicaid for.
Right.
And that's why all these orthopedists are getting, $1 million in revenue, because these the professional orthopedists who are not academic, they're getting all of this rental for all of these braces, and Medicaid pays for braces because it's bodily deformity. So I then, have this data. We're FDA 510K cleared for post-op pain, for physical therapy pain relief, and it's just because vibration in the right frequency is stopping it, but it also gives people control, but it also does ice to reduce inflammation, and it increases blood flow, so you're healing faster. So, all the things, but it is a very simple device. Anyway, Medicaid wouldn't pay for it or give us a DME number because it's a comfort item. So it's electricity and TENS units work very well for neuropathy because they're triggering the light touch nerve. So if you've got a neuropathy, a light touch nerve works. But it's like 40 hertz. It's much slower. It's not
Right.
going to work for severe pain, which is why TENS units usually don't work for intense pain. Also,
Right.
the
I
potential
tried
nerve, yeah, it's really deep. So you've got to have something that's oriented perpendicular that'll go in the right place. So, so what's going on with my product is that there's something called the No Pain Bill that got passed at the end of last year, and that allows for opioid reducing devices. It requires that Medicaid and Medicare pay for opioid reducing devices after surgery. But we've been before the CMS twice now, and we're in the middle of a comment period for a dialysis one. So we may get this Buzzy Pro paid for dialysis because it's a special carve out for pain. But otherwise, the way the system is designed now, Medicaid doesn't pay for comfort, which means that if you want to choose,
This is so silly. They don't pay for comfort. Like it's not about comfort; it's pain.
Yep.
I mean, so what if one of my audience members wants to buy this? They live with chronic pain. They want to buy this product. Could they do that?
So Pain Care Labs, they're $65. They're totally reusable. The
Pain Care Labs, $65. Who cares what Medicare thinks? I mean, come on, $65.
Well, here's even better for your a much happier. Yeah. So plantar fasciitis, knee pain, elbow pain, tennis elbow, those are things that we're covered for. But for free, because a lot of people, $65 is several hours of work for a lot of people.
$65 is 10 cups of coffee at Starbucks. Seriously.
There are a lot of people who can't afford that. But I have a free What Works for Pain download that has, and I'm sure some of the stuff that's in that sleep stuff there is in here. This is all evidence-based, and it gets at the concept that you've got your over-the-counters, and then you've got the supplements, like we've talked about magnesium, we've talked about, yeah. So then it's got your supplements, and then the physical things. So yeah, you got your vibration, you got cold and heat, but also
where can people get that? Where can people get
it's on paincarelabs.com. If you
paincarelabs.com. Let me
look for downloads, and I can get the link for you here. But we've been putting together so many resources for when the TED Talk comes out to try to both address opioid stuff, but also people with chronic pain to try to understand what kind of options can be used to decrease it. So yes, feel free, go buy a Vibracool. That'd be lovely. And please download Pain Care Lab.
The Vibracool have to go where the injury is, or does it block? Is it like a network blocker where you use it and it jams up the signal no matter where it's starting from?
It needs to be in the same dermatome. So,
okay.
And it only works for things where your nerves are working correctly. So
yeah, right.
So
if your nerves aren't working correctly, you either have all pain or no pain at all. So let's.
Well, not just like neuropathy or something, So if you've got a neuropathy, a TENS is going to be better. Shingles, don't use it for that because you've got your nerves are misfiring. But for like when a block wears off after surgery, then you put it in the dermatome. You put it in that nerve pathway where the block was. You just put it above it, and it'll decrease the pain that's downstream.
I'm gonna post this in the comments section right now, so people who are watching on Facebook and YouTube can just click the link that I just posted.
And we just went through.
That's the HubSpot one.
Yeah, the HubSpot one. Yeah, we just went through and updated a bunch of it. Here's a great thing that I learned recently. So even mild dehydration significantly increases pain. So water is a huge thing. And then the other thing that's interesting from a functional MRI standpoint is the more options you're familiar with. So the more you get to know things that are in this book, the more you know, okay, I can try this for sleep.
I can deal with it, right?
Yeah.
Right.
And so it's in the right frontal area of the brain. That is
right where I had my stroke.
Maybe that's why your leg feels
great. Oh, great. No, I want to share what's going on because my audience knows I've been troubled with neuropathy for a while. So the type of neuropathy I have is called small fiber neuropathy. And all of the latest research shows that it's a result of poor blood flow to the nerves. And so how do you increase blood flow? Well, you could take drugs, you could do all sorts of crazy stuff, But so I started using my B strong bands, my BFR bands, blood flow restriction bands, which increase the ability to build muscle, by the way, especially during injury. And I put them on in the morning. I walk for 30 to 40 minutes. Then I get on my Airdyne and I do 6 or 7 all-out sprints. And oh my God, the lactate is insane. My legs burn. But then the rest of the day, the pain is like so much less. And you explained this phenomenon that when I'm doing those sprints, I take the pain threshold up to here. And so when it comes down back to here, it feels like I have no pain at all. But my neuropathy has gotten so much better in just a week and a half. It's ridiculous. So what's going on when I do this to the connectomes and all that sort of stuff?
Yeah. So bunch of things are probably going on. Again, pain is complicated. So the first thing is that in your brain, because you are used to feeling pain here, you have a connection between your identity of a weightlifter, of somebody who is very
loves pain. I love pain.
You've got this memory of, what is the risk of this pain? You've got whatever degree of fear of pain or loss of motion or whatever. You've got the connection that this pain is because I have a problem with my blood flow. This pain, you've got all of these things in connection with that physical sensation. And so 2 big things that are going on. One is that this connectome, this thickness of connection with all of those things, and you feel all of that is one big lump symphony of pain. That connection is now voluntary. You are choosing to increase the pain. And so the meaning of it changes. So your brain no longer, just like the football player who gets, in the end zone, you know that you're going to have that pain. And so you're not as afraid of it. So your brain ramps down. And you also know that you can choose to stop it whenever you want to by taking the bands off. But the third thing is there's something called BDNF that is brain-derived neurotrophic factor. It's like brain fertilizer. And the best thing at deconstructing and constructing these connectomes is BDNF. And what activates it most strongly is 10 minutes of aerobic activity with your heart rate at least 20% above baseline. So you are both instructing your brain that this pain you're feeling is your choice and dangerous. Right. And you're releasing BDNF that is probably very rapidly taking apart those levels of connectomes. So you've got the immediate release when the blood flow comes back, but you also have an ongoing reduction in your brain's paying attention to that area and expecting the sensations to be painful.
Why does phantom pain last so long with people who have amputated limbs and stuff like that? Is that partially the connectomes? One day I closed the browser without hitting end broadcast and came back and found out that the show was like an hour and a half longer than it was supposed to because it didn't get the signal that I was done and it just kept running. Does complete loss of the connection to the connectome during pain cause the phantom pain to just know it's still going on? It never ended.
A couple answers to this one as well. One is there is a really neat new protein that's being studied called the S1R. It's a pain chaperone. So it doesn't matter what's causing the pain, but it comes out in the cells when you've got pain around. So it actually is something that's local. So you can see where the source of pain is. So they've used this in phantom limb pain experimentally to find neuromas. So when you cut a leg and cut a nerve, as that nerve heals, it can constantly be triggering a sensation. So then it just needs to be ablated. It needs to be zapped. And so you can both have an ongoing physical thing that's triggering that nerve. And that's why you're getting a phantom pain, because you've got a pressure and you've got the way that it's healed up is triggering it. And when you have pain that keeps coming from an area, your brain becomes better able and more sensitized. It becomes an expert on pain from that area. So anything that it feels is amplified.
Is it nerve scarring then that where it heals? I wonder if the thymosin beta 4 would affect that by sequestering actin.
Ooh, I wonder if
Causing,
you gave
causing
it,
a lack of scarring.
if you gave it right at the time of
Yeah,
amputation or immediately after. That's a really cool idea.
probably for the next few days while the healing process. Because I scarred my right cornea, and the doctor told me I needed a corneal transplant. And the guys at TaylorMade made thymosin beta 4 eye drops for me.
Oh wow.
And I can see almost perfect out of this eye. They were amazed. The Dr. Paracha, who was like, no, you need corneal transplant. And I said, but aren't I going to have to use like corticosteroid drops for the rest of my life? He says, yeah. I said, then I'm going to get a cataract. He goes, well, then we'll remove that. I'm like, this is the logic of modern medicine. Well, we'll just remove that. We'll just do a surgery for that. I'm a nice guy. I mean, this is the standard of care. But I used the eye drops made with thymosin beta 4, and he couldn't believe the little cloudiness I have in my cornea is ridiculously small compared to the injury, because the thymosin beta 4 kept the scar from happening.
Yeah, I'm excited to learn more about that. But that it's from just learning about it from you before we went on. I think that's a fantastic idea for where to use it. And
older people need it because it reduces all that fibrotic tissue that we build up as we age that causes aches and pains and stuff like that.
Well, and
so,
back to pain again with movement. There are direct channels between muscles and movement areas of the brain that we did not think were involved with pain, but they direct to some of the areas that perceive pain. So the more you move and nothing bad happens, the more you can make your brain stand down and decrease that pain sensation. So Craig was like, he's using fascial stretching. I am absolutely all about fascia as the next way to deal with chronic pain. So strengthening and fascia and just any kind of movement is decreasing the threshold in the brain that gets worried and that amplifies what you perceive as pain.
Right. No, it's fascinating. So did we not cover anything that we need to cover in this discussion that you covered in your TED Talk?
I do have a really cool hack for very acute pain.
Okay.
And so the acute hack is, so it turns out that switchboard I talked about earlier, right?
Mm-hmm.
So it's called the anterior cingulate cortex, and it is the thing that will then direct what is the experience to memory and to the amygdala and to the meaning area and to the area we're sorting through options. So it is also the area that deals with cognitive dissonance and cognitive conflict. So what you can do is give your brain a thinking slow task. So if anybody's read Kahneman, thinking fast, thinking slow, thinking fast is when you're jumping to conclusions or quickly looking at something, or something that you're good at, but thinking slow is something where you're having to make decisions. So a really good example that I came up with is if you're getting a dental procedure or something painful is happening or somebody's drawing blood or whatever, look at a sentence and count how many of the letters have holes in them. And what that does is, as you're counting, see, A has an A hole, Carl, A, 1, 2, 3. So, thinking about how many 4 letters in your name have holes in them, the effort that it takes to recategorize what you're used to reading as a word and thinking about it as a shape. You're done with the procedure and it activates your anterior cingulate cortex. It reduces pain by half because it's not connecting to all of those ancillary areas that are part of this symphony of pain. And so it reduces pain.
Fascinating.
Great short-term hack. Yeah, it's really good.
Cool. That's cool. It's just like sending your mind to do a task it's not used to, and you got to focus completely on that and nothing else.
Right. And when that part that's focusing on the task is also responsible for laying down the connections to everywhere else in your brain, then you don't do it. Then you can't feel as much pain. It's busy. Sorry, it's counting a-holes.
Right. A-hole. I like that. A-holes.
Yeah.
I have one more
okay.
sponsor to plug, and then we're going to also plug your website again. I've been sleeping with grounding sheets. I have a grounding bed cover and I have a grounding pillowcase. I can tell you unabashedly, and I track everything. The level of deep sleep and the duration of deep sleep has increased dramatically. The research on grounding is legit. If you start doing some digging around, you'll find out it is. The folks over at MedBeds, if you go to shrnetwork.biz/wellness-solutions and use the code SHR, you'll save 5% off. If you want to prove this to yourself, get the pillowcases, because you'll sleep grounded, because that, people say, oh, go stand out in the grass. Lay on a pillowcase that's grounding you for 8 to 10 hours and watch what happens. Watch how good you feel. It reduces inflammation in the body. It has profound effect on changing the viscosity of blood in minutes. I mean, it's magic, this stuff. And remember, through evolution, we were grounded a lot more often than we are today. So again, shrnetwork.biz/wellness-solutions. Check them out. And then, of course, let's get Dr. Amy's information up here again. It's called paincarelabs.com. You can go there in spring for $65 and get the unit if you're dealing with pain. And also, can they download the guide there as well?
Yeah, if you go to Pain Care Labs, and then there's resources, and then downloads, and then scoot down a little bit, and it's called What Works for Pain. And it looks, we got a picture of the download on there, and you can download the workbook for free.
Yeah, very, very cool. Yeah, and if you pick up one trick from that, it could change your life. Seriously, because we all deal with pain from time to time. And then, of course, Sean Wasson says he got his grounding cover for his bed. It's magic. I'm a big fan of grounding. I understand the value of it, but the idea of sleeping for 8 to 10 hours grounding is a game changer. It really, really is. I think that's it. Unless you have anything else you want to convey to the audience before we go.
Just hashtag options, not opioids. And there is no one right answer. Don't give up. Just keep trying something, layering it, trying a different combination. There's an infinite number of ways you can put together brain, body, physical supplements over the counter and get to a place where you're more comfortable.
I love that. Options, not opioids. Thank you very much for being here today, Amy. Hope we see you soon again, okay?
It's such a delight to be here. I always enjoy talking to you.
Take care. All right, we'll see everybody next week. No more shows this week, but next week we have plenty more. So tune in then. And don't forget, share the shows. This is a show that you could share, and someone that you care about can get one thing out of the show and change their lives. So please share the shows. All right, see you later.